I agree.
Yes, yeah, this is a good one. So it's mainly peripheral, basal, subpleural here. If you look at the high resolution CT, you'll see the subpleural involvement, right?
Is that traction?
So that's traction bronchiectasis, which is what? What is traction bronchiectasis?
Because in the fibrosis, you're gonna build the wall of the bronchi and causing the cystic cylindrical shape.
So traction bronchiectasis is bronchiectasis or cystic dilatation of the airways because of loss of the interstitial support. What is the difference between traction bronchiectasis and the usual bronchiectasis? In these cases, you don't have airway thickening. So usual bronchiectasis, you have airway thickening and dilatation. Okay. In traction bronchiectasis, there is no thickening of the airways. They're dilated because of loss of the interstitial support, so they get dilated. Okay. Classically in interstitial lung disease or diffuse lung disease. So treatment is usually very limited because they are non-responders to steroids. Why? Because they present at late stages with fibrotic stage. If you have fibrotic stage, honeycomb in the high resolution CT, they're unlikely to respond to steroids, right? People who respond to steroids are those who have ground glass opacities on high resolution CT, which means they still have an active, ongoing inflammatory reaction. So if you hit them with anti-inflammatory agents, they may respond. But if the inflammation is gone, there's just remnant of fibrotic changes, then probably they're not going to respond to any treatment.
So it's a healing process.
Exactly. This is like an advanced fibrotic stage now. Okay, survival is like limited at 2 to 5 years, very limited.
So Mazen,
you need to remember that. I'm sorry, just immediately finish. So steroid response is very limited. Prognosis is bad. They could be candidate for transplant, maybe. Treatment is usually oxygen when they have resting hypoxemia, or even hypoxemia on exercise. You may supply them with oxygen. If they have also nocturnal hypoxemia, you have to give them oxygen. Treat their pulmonary hypertension because nowadays we know that presence of pulmonary hypertension is more prognostic sign in those patients. If you treat their pulmonary hypertension by vasodilator, you improve their exercise capacity and their 6-minute walk. Okay. There's one more thing. Yeah, that's it. So the next one is the NSIP, which is the non-specific interstitial pneumonitis. Non-specific interstitial pneumonitis is a kind of the same disease, which is on the other spectrum. So it's mainly in younger people. Okay, they have more of the active stage of the disease, so they have more ground glass opacities, not that much of fibrotic changes on the CAT scan. Okay. So those patients are more responders to treatment with steroids, and they have better prognosis, of course. Okay? Is it clear?
Yes.
Good. Okay. So just remember, it's a kind of a milder form of IPF. ERDR stage respond better to steroids. Pneumonitis, yeah. IP. Okay. And they're usually younger than IPF patients. Okay. RP-ILD and VIP, the respiratory bronchiolitis, interstitial lung disease, and the ischemic interstitial pneumonia or pneumonitis. So these two categories are actually the same disease with different, again, different stages. RP-ILD is more proximal disease, so it involves the bronchioles. Okay, so they have bronchiolitis element, and their disease is more advanced at the time of presentation. They have more fibrotic changes. VIP is more distal disease, so they have more alveolar involvement, and most of the time they have more ground glass opacities on imaging, so they are more responsive to treatment with steroids and immunosuppressive agents. So this one is better than this one, because this one responds more to anti-inflammatory treatment. Okay. Now, this entity is also strongly associated with smokers, and as I said before, RBILD is called smokers bronchiolitis. It's associated also with cystic changes, emphysematous changes at the apices. Okay, and it is one of the diseases that has the mixed obstructive restrictive pattern, because they are smokers, they have cystic changes, they have obstructive components on top of the interstitial components, so they have both restrictive and obstructive pattern in the end. Okay? I think that's
The can you tell us more about obliterating bronchiolitis?
It's stealth. I didn't really talk about it yet. I will talk. Next is AIP. We talked already about AIP, acute interstitial pneumonitis or hemorrhage. It's basically non-cardiogenic pulmonary edema in the absence of cells, right? It's a very acute onset, usually days to weeks, few weeks, usually days. Prognosis is bad. We have high mortality rate, about 50 to 60% mortality. Treatment is usually supportive. Ventilator support most of the time. And nothing much to remember about. Okay. COP, which is the cryptogenic organizing pneumonia, is an interesting disease that usually presents where the subacute presentation, so they have like cough, shortness of breath, sometimes constitutions of fever. They present like pneumonia initially, and they have patchy alveolar filling with also some bronchioles involved. So on imaging, they look like pneumonias basically. So those patients classically get treated with antibiotics first, with no significant response, and they come back in a few weeks. You get the chest X-ray, again you will see basal involvement more than apical, bilateral, patchy, alveolar, with some interstitial changes as well. And treatment is steroid. They respond very well to steroids, right? Relapse after, so this is cryptogenic organizing pneumonia. It looks like pneumonia alveolar filling. At the same time, there is some bronchioles involved as well. Remember, it's mostly basal, right? And as we said, it's one of the diseases that are usually peripheral. It's one of the negative or photogenic negative pulmonary edema, so it's more peripheral than central. Pleural effusion is rare. You don't see pleural effusion with cough. Okay. Another sign that you may see with cough is called negative or reverse halo sign. Halo sign is classic of invasive, acute invasive aspergillosis. Negative or reverse halo sign is classic, very characteristic of cough. Okay. In the past, they used to call it BOO, bronchiolitis obliterative with organizing pneumonia. Nowadays, they say if you have an underlying cause, because cough can be associated with connective tissue diseases, drugs, infectious etiologies sometimes. If you have something that you know, this is probably secondary to drugs, then you can call it BOO, bronchiolitis obliterative with organizing. But if you don't know, if it's idiopathic, then you have to call it cryptogenic. Some people prefer to call it just cryptogenic for everybody. So it depends. Most of the time nowadays they call it just cough, cryptogenic organizing pneumonia. Okay, but remember to look for underlying drugs, malignancy, infectious, not malignancy, connective tissue diseases, and drugs maybe. Okay. What else? LAM or LAM, lymphangiomyomatosis, and histo are kind of similar diseases. LAM is exclusively seen in females of childbearing age. They present with recurrent pneumothoraces because they have diffuse cystic changes on their CAT scan. This is not a great one, but you can see diffuse cystic changes on the CAT scan. So when these fully rupture, they present with pneumothorax. They're young females again. Sometimes they have extrapulmonary manifestation, mainly uterine fibroids and renal and lipomas, whatever. Not lipomas, whatever. Anyway, so benign tumors of their kidneys and uterus. It's believed to be secondary to abnormal formation of thoracic duct and lymphatics, so they have chylus effusion as well. So they have chylus effusion, chylothorax, and they have also lymphedema. Or I'm sorry, not lymphedema, just chylothorax. So they have chylothorax, recurrent pneumothorax, and cystic changes on the CAT scan. Young female treatment, and they get worse with pregnancy or estrogen therapy. So it's related to estrogen and hormones. We don't know exactly how. Treatment sometimes is manipulation of hormones, not very effective. Most of the time they need lung transplant.
Do we need tissue for diagnosis or just CAT scan?
High resolution is very characteristic in those patients. If you are in doubt, you can get a high resolution CT. You don't have nodules on the CAT scan. That's a kind of interesting difference between LAM and histo. Histocytosis X, they have also on top of the cystic change, they have also micronodular pattern. Histo is usually upper lobes. LAM is usually diffuse. Histo is mainly smokers, young males. LAM is exclusively in females. So the presentation is sometimes similar. Recurrent pneumothorax is diffuse cystic changes on CAT scan. One of them, okay? Histocytosis, as we said, can be extra pulmonary manifestation, can be either central diabetes insipidus, very classic, hypernatremia, and they can also present with bone disease, cystic bone disease, especially in kids. And I think there was a question on endocrine mix-up, one of the mix-up endocrinology about somebody with central diabetes insipidus and I think uveitis. So two lung diseases that you have to remember for if you have central diabetes insipidus and shortness of breath, two diseases, sarcoid and histocytosis. They present to central DI. Okay. Good. One more disease called LIP or lymphocytic interstitial pneumonia. It's lymphocytic, so it's mainly seen in patients with lymphocyte disorders. Patients with Waldenstrom, very classic, multiple myeloma, lymphocytes. Patients with HIV, that's another lymphocyte disorder. Patients with lymphoma sometimes. Patients with graft versus host disease, that's another lymphocyte disorder. So if you have somebody with a lymphocytic disorder presenting with interstitial lung disease, think of LIP, lymphocytic interstitial pneumonia. Okay. It can be idiopathic or secondary. Treatment is usually treated in the line course. They have lymphoma, treated lymphoma, Waldenstrom, treated in the line course.
Tissue
That's
diagnosis.
Sorry. It is a tissue diagnosis, but so let's go to the question.